We're going to go ahead and get started, excuse me, talking about babies with supplemental tube feedings and what can we do to help them, okay? So as we've already been talking about, these babies are like every baby. We will have some special things to think about, but really these are the same babies that we've been talking about in terms of interventions to help them get off of tubes. So these are the learner outcomes. Describe at least one effect of long-term nasogastric tube use on feeding development. List at least one factor that impacts how tube feeding affects the development of eating and drinking. And then summarize the benefits of nasogastric tubes over G tubes. So we have some things that make nasogastric tubes more challenging and some that make the feedings even better or outcomes better. Okay, so we have to remember that in the first 2 years of life, this is when we learn about eating, okay? And so the skills and habits in this time frame are going to set that stage for the rest of your life. And the first 2 years appears to be very critical in this development, okay? The role of pleasure of eating is developed in this time frame. So we can certainly get children off of gastrostomy tubes or nasogastric tubes when they're over 2 years of age. But what we find is they're not really excited about eating. They eat because, you know, you have to eat to grow. And you've heard me say throughout this whole series, my preference is to get babies to love to eat. Food experiences are really important to be thinking about here in this first 2 years. Okay? We want to be thinking about the fact that in the first main time where babies are learning about flavors and eating are the prenatal and lactation periods. We've talked a lot about that the flavors come through the breast milk. The next appears to be complementary feeding. And so if you are working with babies on tubes in any of those time frames, we need to be thinking about, wow, how are we going to teach them about eating? Whether your baby goes home with a nasogastric or a gastrostomy tube, out of the neonatal intensive care unit, what I find is highly dependent on where you are. Also, do you have easy access to someone who can put gastrostomy tubes in? Pretty much everybody in neonatal intensive care units can put in nasogastric tubes, okay? What they found was there were more emergency department visits in babies who had gastrostomy tubes compared to babies with nasogastric tubes. Now, one of the things that I'm going to point out is frequently babies who have gastrostomy tubes coming out of the neonatal intensive care unit have more challenges. And so the fact that nasogastric tube feeding was associated with fewer ED visits may or may not be because of the tube. It might be just because of the underlying health of the baby. Okay. More babies in this study reached full oral feedings when they went home with nasogastric tubes. They were able to transition more quickly than gastrostomy tubes. What you're going to see in an upcoming study is the reverse, that after a period of time, if you still have a nasogastric tube, it takes you longer to come off and onto full oral feedings than it does if you get a gastrostomy tube. So some of this has to do with whether or not you are coming home with the one or the other and how long you end up having it, okay? This is another study, 20 infants with a nasogastric tube who got a G tube within 6 months. The average amount of time was about 2 months, 67 days, and poor oral intake was the reason in most of the babies, as well as concerns for aspiration or apparent life-threatening events, okay? So depends. I always say one of the things that I look at is, what is your progress rate? Are you making progress, and is it fairly decent? Because that's my best guess as to how long it's going to take you to get off the tube. Okay? And so for some babies, I think, wow, I think this baby's going to come off within 3 or 4 weeks, and they could be doing that at home. Now, I will tell you, in my nursery, we don't send babies home from the neonatal intensive care unit with nasogastric tubes. That is a very rare thing. If you're not able to reach full oral feedings, we send you home with a gastrostomy tube. We are very comfortable holding you in our hospital until 40 to 42 weeks. And it depends on the parent, and it also depends on your underlying diagnosis. Some diagnoses, like Prader-Willi, there is a recommendation to not use a gastrostomy tube. So I do some of that kind of homework as well, okay? So it really kind of depends on where you are in terms of going home with nasogastric or gastrostomy tubes. All right, so when we start looking at gastrostomy tube placement, more often these are babies who were older when they first started oral feedings, which is probably a surrogate for either respiratory problems or other medical issues. They were sick enough that they weren't able to start oral feedings sooner. Okay, they're more likely to have lower birth gestational age, more often have high frequency ventilation exposure, which can cause lung damage like BPD. And they're more likely to have necrotizing enterocolitis, especially if they end up with surgical interventions for that. Okay, so the percent of gastrostomy tubes are variable from place to place, and you have some of those risk factors. In this study, out of the babies who got the gastrostomy tube, by 18 to 22 months, only a third of them were fully orally fed. Okay, we do see that oftentimes babies who get tube feedings remain on tube feedings for months, if not years. And I think we can make that better. I do have hope for that. So we're going to go back to the report for this consensus conference for standards, competencies, and best practices. And I want to just remind you that feeding experiences are behavior-based and baby-led, whether applied to tube feeding, breastfeeding, or bottle feeding. Okay? We also know that nutrition needs to be optimized. That's why babies get tubes, is so that we can get good nutrition in them to help them grow. Good growth helps with good development. Better development helps with the development of skills to get off the tubes. There are reasons for this and why we look at these different factors. When you educate parents prior to putting in gastrostomy tubes, that can help decrease some of their stress. They have fewer medical visits after discharge, fewer emergency department visits, and fewer readmissions. One of the best things I ever did was I hounded a G-tube salesperson at a conference, and I just wouldn't let it go. And I finally got him to give me his doll that he uses to be able to put the G-tube in to show people, how his special G-tube worked, etc. But now I have that doll. And I can tell you, if we start talking about a gastrostomy tube with a family, I bring the doll in and I show them, what are we talking about? If you say it's just a tube going into the tummy, that sounds horrific. But if you can show them, that in and of itself is helpful. Also, ask lots of questions and anticipate things. The biggest concern after what does it look like that families have shared with me is when we talk about putting in a tube, in their head, two things. One, it means that their baby is devastated and is never going to have a typical life. And number two, that if we put in the tube, we stop orally feeding them. So you want to dispel those myths, okay? And help parents understand, right now your baby is struggling with feeding by mouth. He's going to get bigger. We're going to keep working with him. And our goal is to get him off of the tube. So one of the other things that I've come to appreciate over my 30 years of doing this work is most families, most of us, have seen people in our environment in wheelchairs or with other developmental issues or with, some hemiplegia or language delay, okay? Most people have not seen people with gastrostomy tubes where they know the person has a gastrostomy tube because it's under clothes. We have little children all the time running around, talking and playing, and they have a G tube. And so it's a conceptualization that I think we can help with when we talk to families, okay? Nasogastric tubes have to oftentimes be put in and taken back out. That can be very painful for babies, and we have some documentation that is in fact difficult for babies. So we want to think about that. How do we help people understand, how do you replace them? They're going to come out. How do you help parents know how to use the nasogastric tubes and to put them back in? This is part of why in my facility, we don't teach families how to put nasogastric tubes in babies. We just feel like that is asking a parent to be a medical professional. In fact, I had a dad, this family has since become good friends with me, but I was working with them. Their daughter had Prader-Willi. The father was a physician, and he wanted to take his baby home. And he said, just put in a she has a nasogastric tube, and I want to just take her home. We can put that back in. And we were basically pushing back and saying, no, we're working with her. She's getting better. And we don't send babies home with nasogastric tubes. Now with Prader-Willi, we understand that might be an appropriate thing to do. But at the time we did it, and Dad said, finally kind of put his hands on his hips and he said, I'm a physician. I can do this. And one of the rare times that I forgot to use my editor when I'm working with families, I said, and you're her daddy and you shouldn't have to. And I didn't mean to be quite so direct, but the idea is it's hard to lay your baby down and to put in tubes when they're crying and screaming. So that baby actually ended up transitioning to full oral feedings prior to going home. So one of the strongest indicators of successfully transitioning off the nasogastric tube is the percent of prescribed volume taken orally on the day of discharge. So if you're really close to reaching full oral feedings, or maybe you're at 60 or 70%, those babies are much more likely to transition off of the nasogastric tube. If you are at 20% and you've been at 20% for 3 weeks, the chance that you're going to come off quickly is pretty low. And so that's another criteria that we look at. So we've talked a little bit about some of the benefits of nasogastric tubes. We also see in the literature that there are negatives. This is a study of 20 preterm babies, and they found if the baby needed nasogastric tube feeding for more than 3 weeks, they had significantly more facial defensive behaviors and significant delays across more aspects of their feeding development. But I want you to notice these were your older preterm babies. So 3 weeks is for at least the 37-weekers, now you're at term. So I can understand this for your 32, 33, 34-weekers. Most of those babies are going to come off within 2 to 3 weeks. Don't assume that a 26-weeker who has a feeding tube, a nasogastric tube, for more than 3 weeks is at a similar higher risk, because from my perspective, the research shows that the gag reflex comes in around 31, 32 weeks. And so I sort of don't count the time frame before that. Okay, this is another study, but here they see food refusal associated with nasogastric tube exposure for greater than 3 months. And growth outcomes are better if you're on gastrostomy tubes. So G-tubes are going up in terms of placement in the US, especially in the babies under 1 year of age. Parents will report after getting a gastrostomy tube, usually it improves their life. This frequently is for your older child, your 1, 2, 3 year old, okay? But they don't like it. Parents still don't like the tube, and I don't blame them, all right? So if you have a tube, regardless of nasogastric or gastrostomy tube, we want to think about these 5 factors, okay? Medical complications. Why did they get a tube in the first place? If you got a tube because you were aspirating, it's going to influence what's going to happen when we try to get you off the tube. If you're still aspirating, you can't transition off of the tube, right? If that's why you got the tube. So that's number 1. Number 2, the age when we start oral feeding. Sooner is better, pretty much across the board. Methodology of tube feeding. And you see with your older babies that you want to be thinking about getting them off of a nasogastric and onto potentially a gastrostomy tube. Okay? Exposure to tastes and textures during sensitive periods, and what kind of aversive experiences does the baby have. These are 2 other main factors that we can absolutely help with. So decrease the negatives and keep them on a schedule where they're getting smells and tastes that are biologically expected for that age. Okay, we're talking about babies, so it's breast milk and formula. But if you're working with babies and they're reaching that 4 to 6 month age range, then the exposure is pureed foods or starting to move up into some of the soft foods, okay? So the goal of any tube feeding is to provide optimal nutrition, and ideally it's supplementing what the baby can do by mouth, okay? Which means that if they are orally feeding, we want to protect what they're doing with their mouth when they get a tube, okay? We have lots of stories that when the tube goes in, the oral feeding goes away, and we can make a difference in that outcome, okay? And that's sort of what I'm going to be talking about. First that we want to think about is oral feeding or tube feeding. You want to think about what are the experiences that the baby should be getting. And that's not just the smells and taste, but it's also inside the body, okay? So what does my tummy feel like when it's getting full? Does it go from empty to extended? Or does it go in a slow, steady manner like it would if I was eating? Am I sitting up at the table with your older children? Or am I being held when I'm breast or bottle feeding? And am I being held when I'm getting my tube feedings? So we do not tube feed babies laying on their back in their bed or younger children laying in front of the TV. Okay, that's not how we eat. That's not the experience we want babies to get. I will say for babies going home, I do also remember being a parent. And so we would want them to be held during the day. I do kind of take a hands off for letting the baby sleep during the night, okay? And the parents. We start with physical comfort, okay? Everything should be comfortable. And when people say, well, all babies who are gagging and retching, that's just what happens when they have tube feedings, that's not true. So we continue to use our standards. We've been talking about these, for this entire course. So hold when they're getting their tube feedings, okay? That can help them to learn about their role of waking up. You can offer tastes and smells. That helps with the sensory development, okay? We want to be helping babies understand what is their role. With your younger babies, snuggle during tube feedings. Okay? Babies are more stable. That's going to help with digestion, and it's going to provide the right kinds of inputs. Okay? Getting flavors, just like we've been talking about with other babies, these babies with tubes still, we want to be providing the same kinds of inputs. Okay? Watch their behaviors. That's how they communicate. So if they are showing instability or discomfort during tube feedings or after tube feedings, that's really relevant information. And we need to start there. I don't have the answers to why the baby's uncomfortable, but I become very focused on why is this baby uncomfortable when their tube is filling up their tummy, and how do I make that better? Gagging and retching. Okay? Oftentimes people say, oh, this just happens, after a tube is placed, it just happens. We have some research that shows that the tummy is more sensitive after tube feeding, but if I'm gagging and retching, I'm not going to want to eat. And gagging and retching is also associated with nausea, which is going to decrease my appetite. So when I have a baby who's gagging and retching, I'm working with a dietitian and we're playing around with things like maybe he's getting too much volume in his tummy. Maybe the food is going in too fast and we need to slow down how fast the food is going into their tummy. Okay? If we play around with things like volume and how quickly it's going in, then if the baby is still gagging and retching, we start down a different road. We start down the medical road. Do we have a GI issue? Do we have a neurologic issue? Do we have a respiratory issue? And all of these are possible. And do we have a nutrition issue? Gagging and retching may be because the volume is too much. It may be because it went in really quickly. It may be because what you're feeding the baby, they're not tolerating. Remember, intolerances are GI-based discomfort. Sorry. So enteral pump feedings or gravity feedings. So with my little baby right here, I'm going to show you what I'm sort of thinking of. So when you have a baby going home with a tube, whether it's nasogastric or from the tummy, many times the parent goes home with a syringe. And what happens is we ask them to fill up the syringe and first attach it to the tube, okay, fill up the syringe, and then try to make sure that it doesn't go in too fast, doesn't go in too slow. If your baby kind of has these little gagging motions, slow it down, and you can do that by raising and lowering the syringe. However, a human being cannot possibly do it as controlled as a pump. Okay, so if you have an option of getting a home enteral pump, that would be my recommendation for most babies. Okay, not all babies, but most babies. And they look different than the pumps in NICU settings. Okay, so once the baby goes home, I actually love using an enteral pump instead. All right, gravity feedings, you always need a parent there or a professional there. You don't want to be just hanging this and leaving it for the baby. Okay, so parents can follow the baby's lead when they have a syringe, and that certainly is one way to improve comfort during enteral feedings. But if you start thinking about the older baby, one of the other benefits of an enteral pump is it frees up my hand. So how am I supposed to offer the bottle or taste on a pacifier if I have to hold this and I have to hold my baby? If I have a pump, the food goes through the pump, I set everything up, I connect it, I turn on the pump. Now I have an extra hand. Now the pump is doing the work and I have this lovely engagement with my baby. I can provide smells and tastes, I can interact with them, and the pump is doing all of the work. So that's one benefit. Another benefit is that the pump is going to take the syringe out of the visual field of the baby. If this is my pump, I'm just going to use a plunger as an example. If this is my pump, my syringe, and I have to look at it to make sure that it doesn't empty and it's not going too fast and it's not going too slow, I'm paying attention to this. My baby will start paying attention to this. I don't want them to be looking at this. I don't even want them to know that this is where the food comes from. What I want them to think about is the bottle and just the bottle. And so I want to associate this with eating. Okay, so every baby is different, but in general, I love using enteral pumps if the baby is going to be on tube feeding for an extended period of time. Now, here is the other question that I get all the time. Well, when do you start the pump? In hospitals, most of the time, what we tell families is you can have 30 minutes for feeding. So when parents go home with a baby who has pump feedings or tube feedings, what they like to do is give them 30 minutes to try eating and then finish with a pump. That's going to start adding up. It's going to be an hour, hour and a half for feedings. What parents will tell you is, feels like all I do is try to manage, feedings. I mean, I finish the feeding, I wash everything, I start it all over again. We want parents to be parents. We also want normal experiences for the tummy of the baby. So in general, I'm going to think about, well, how much does the baby actually eat? Even if I gave him 30 minutes, if he's taking 10%, 5% of what he needs to eat orally, hunger is not why he's not eating. So I'm going to turn on the pump and I'm going to feed him at the same time. Okay? If parents say, oh, but what if he starts eating great? Pause the pump. Okay? So this is not a hard and fast black and white rule. But I generally say if they're taking less than 10%, start the pump at the same time as orals. You can see this would be challenging if you did not have a pump. If the baby starts taking 25% of their feedings by mouth, then start the pump after 5 minutes of the baby orally feeding. 50%, start the pump after 15 minutes. Okay? So what you're doing is you're giving the baby longer time for the orals if they are showing they're eating larger volumes. But you're still trying to start the pump so that pump plus orals are done in 20 to 30 minutes. Okay? Now, some babies can't handle it that quickly. And if that's the case, that's fine. Maybe you're going to have a 45-minute feeding, but I start to try and kind of squeeze things down. Okay? So when it comes to feeding babies with tubes and working with babies with tubes, what I tell people is basically think about babies are babies first. So you're going to do all of the things that we've been talking about, and the experience should look pretty much the same, whether the tube is giving them the food or their mouth is giving them the food. They're being held, they're being talked to, they're getting smells, they're getting taste, everything as is medically able to happen. Okay? If babies go home with tubes, many times, depending on the medical condition, they're going to have it for a while. And so we just want to kind of think about that. All right. So we have some key takeaways here. Because of time, I want to kind of jump into our general key takeaways, okay, and kind of wrap up this series. When babies are going home, when parents are going home, some of the defining attributes is that they're having a mix of emotions, they have some uncertainty, and they feel like they're finally coming into parenthood. So how to help? Make sure that they have been participating as parents with their child's cares as much as possible, and form a partnership with them, collaborate with them, and come up with a plan for them. Because after all, it's not just babies are babies, but families are families. And from birth, we want families to feel like families, supporting their parental role, providing opportunities for nurturing and learning and supporting them as they learn to breast and bottle feed their babies. We want to encourage their self-competence and enhance their expertise and help them to recognize and respond to their infant cues. We have, as your next steps, that you need to access your quiz. You'll go back to your dashboard. That's where you'll find the quiz and you'll find the evaluation. And after you complete your quiz and your evaluation, then you're able to download your certificate of completion. And if you have any questions, please go ahead and contact us at info@feedingfundamentals.com and we can help step you through that process. And remember, if you are requesting continuing education credits, specifically we have American Occupational Therapy Association and American Speech and Hearing Association CEU credits. You must have given us your member number when you registered. It would be wonderful if I could see you again at some point in the future. Thank you very much.